Henoch Schönlein purpura. Key points. Urinalysis and blood pressure measurement must be done when Henoch Schönlein purpura, HSP, is suspected. Most cases are self-limiting and only require symptomatic management. Close follow-up is critical to identify significant renal involvement requiring intervention. Background. HSP is the most common vasculitis of childhood. It most commonly affects children 2 to 8 years of age. Assessment. HSP is a clinical diagnosis. The features include rash, and one or more of arthritis/arthralgia, abdominal pain, nephritis. History. The clinical manifestations of HSP can take days to weeks to fully develop and may vary in order of appearance. Purpura occurs in all patients but is the presenting complaint in only 75% of cases. Recent upper respiratory tract infection is present in 50% of HSP cases, commonly group A streptococcus infections. Examination. General. Observations. Assess for blank. Features. Blood pressure must be measured at initial presentation and at follow. Up. Skin. Assess for palpable purpura, petechiae, and ecchymosis. May be preceded by urticarial, erythematous, maculopapular, or bullous skin lesions. Painful non-pitting subcutaneous edema. Features. Usually symmetrical. Located on gravity/pressure dependent areas, e.g. buttocks and lower limbs in ambulatory children. Commonly periorbital, in non-ambulant child, and/or dependent. Areas, hands, feet, scrotum. Joints. Arthralgia plus/arthritis, usually affects large joints of lower limbs. Rarely upper limbs. Usually no significant effusion or warmth. Abdominal, diffuse abdominal pain. Generalise tenderness. Signs of bowel obstruction. Peritonism. Blank. Others include GI hemorrhage, bowel ischemia, necrosis or perforation, protein-losing enteropathy, pancreatitis, genital, testicular pain, /orchitis, necrosis, cord hematoma, exclude testicular torsion, respiratory distress, diffuse alveolar hemorrhage. Neurological, rare, changes in mental status, focal neurological signs, label mood, apathy, hyperactivity, encephalopathy. Consider intracranial hemorrhage. Urinalysis, hematuria, microscopic or macroscopic. Proteinuria, mild to severe. Proteinuria/hematuria, nephrotic syndrome, acute nephritic syndrome, hypertension, renal impairment, renal failure. Management. Investigations. Urinalysis is usually the only investigation needed in a classic presentation of HSP. If there is hypertension, macroscopic hematuria or significant proteinuria, also perform formal urine microscopy and urinary protein creatinine ratio, UEC and albumin. Additional investigations may be required to rule out differentials if the diagnosis is unclear, e.g. ITP, leukemia, meningococcal infection, or to identify potential complications of FBE, UEC, albumin, blood and urine cultures. Abdominal imaging. ASOT and antidenase B. ANA, dsDNA, ANCA, C3, C4 if significant renal involvement with an unclear diagnosis. Treatment. Mild pain. Regular paracetamol and a short course of NSAIDs such as ibuprofen, 10 mg per kilogram TDS, or naproxen, 10 mg per kilogram BD, can be used if not contraindicated, e.g. GI bleeding or renal impairment. Subcutaneous edema is managed with bed rest and elevation of the affected area. Moderate severe pain. Consider the use of steroids, glucocorticoids, in children with moderate to severe abdominal and joint pain, may reduce duration of symptoms. Steroids do not impact the rate of long-term renal complications of HSP. If prescribing oral prednisolone, give 1-2 mg/kg/day, maximum 60 mg per day, or 4-methylprednisolone 0.8-1.6 mg/kg/day, maximum 1 g/day, while symptoms persist. Once symptoms have resolved, an appropriate weaning regimen should be used. Follow-up. Regular GP or pediatrician review is critical to identify subsequent renal involvement, which rarely requires a renal biopsy /immunosuppression. If initial urinalysis is normal or only reveals microscopic hematuria, review clinically and check BP/urinalysis. Weekly for the first month after disease onset. Fortnightly from weeks 5 to 12. Single reviews at 6 and 12 months. Return to weekly reviews if there is a clinical disease flare or additional signs of renal involvement. If there is no significant renal involvement and normal urinalysis at 12 months, no further follow-up is required. Consider consultation with local pediatric team when. Consider admission. Serious abdominal complications. Severe debilitating pain. Severe renal involvement, see UPCR values below. Neurological or pulmonary involvement. If treatment with prednisolone is considered. The development of hypertension, proteinuria, or macroscopic hematuria at any point should prompt a pediatric review and the investigations as outlined above. Consider consultation with a renal specialist when. Hypertension. Macroscopic hematuria for 5 days. Abnormal renal function. Nephrotic syndrome. Acute nephritic syndrome. Persistent proteinuria. UPCR and GT 250 mg/mol for 4 weeks. UPCR and GT 100 mg/mol for 3 months. UPCR and GT 50 mg/mol for 6 months. Consider transfer when. The care required for the child is beyond the comfort level of the healthcare service. Consider discharge when. Appropriate follow-up has been arranged. Discharge advice. Prognosis. A first episode of HSP, in the absence of significant renal disease, usually resolves within 4 weeks. Rash is often the last symptom to remit. Joint pain usually resolves spontaneously within 72 hours. Uncomplicated abdominal pain usually resolves spontaneously within 24 to 48 hours. Than previous episodes. In 25 to 35% of patients, HSP recurs at least once, within 4 months of the initial presentation. Subsequent episodes are usually associated with milder symptoms that are shorter in duration than previous episodes. 90% of those who develop renal complications do so within 2 months of the onset, and 97% within 6 months.